Hello, Kidney Warriors! I was just there talking to my co-host, getting ready to start. Hey, my name is James, and this is Dadvice TV, episode number 337, helping empower you, the kidney patient, with knowledge from real kidney professionals. Now, today, wow, do we have a great topic to talk about. We're going to talk about the SGLT2 drugs, which can be a game changer for kidney patients. We're also going to talk about my own personal experience on an SGLT2. And the good news is I got labs right before I started, and then I've had 3 sets of labs since that time. And we will talk about that, share what happened to my kidney function and where it is today. I got my latest labs just 2 days ago, so these are fresh right out of the oven. All right, now our co-host, you guys know him, you love him. He is the author of the best kidney book out there. As a matter of fact, him and I were just talking about it and how easy it is for us kidney patients who don't have a doctor's degree or anything like that or any medical training to read, understand, comprehend, and make a plan based on what's in his book. It is written for the patient so that you don't need a giant thesaurus and a medical dictionary. That book is called Learn the Facts About Kidney Disease, and you can order it from any bookstore or go to the big giant places like Amazon. If you like that link, go to dadvicetv.com/book. Will take you right to Amazon. But if you've got a mom and pop store that you love that's in where you live, go give them some kindness and visit them. They can order it for you and you get you a copy of it. But my co-host is the author of that book. Please give a great big welcome to Dr. Stephen Rosansky. Hey, Dr. Ro, how you doing?
I'm good, James. I'm good. And I'll introduce myself, and then I want to mention something about the book, which I normally don't do. But I was just talking to James that because the book has been so popular, I was approached to do an audio book. And long story short, I actually hired somebody to do the audio book, and I listened to my entire book. And this is the first audio book that I've ever listened to. And it was great, I have to say. And I enjoyed listening to this guy. He's great. So anybody who likes an audio book, I think next month it should be available for you. So you can listen to it if you don't like to read, which I'm not a great reader. So I may, as James say, I may get into listening to more audiobooks. But
there
anyway,
you go.
James. So I am a retired kidney specialist. I spent 40 years taking care of patients with internal medicine and kidney problems. And I have also a lot of research experience. I've published a lot of basic academic papers. And I have been recognized for my work regarding when to start dialysis. And together with other colleagues, I think I hopefully have helped people not start dialysis too early at higher levels of kidney function. And let me tell you, I've got patients, and I didn't realize because I hadn't read my book for quite a while. I talked about some patients that were saved years of avoiding dialysis because they didn't need to start, and I followed them in my clinic. And if they were taken care of by some other kidney doc, they would have had 3 years of an unpleasant experience. Dialysis is not fun. So that's my deal. And tonight, we're going to talk about an extremely important subject. And we've got some other shows where we talk about the issue of proteinuria. It's a critical issue in terms of progression of kidney disease. And everybody should by now know the drugs that I think we mention almost every time were on the show, and those are the drugs that have been shown to benefit kidney patients. They should be the first drug that you get treated with for high blood pressure, which is the vast majority of you folks, I'm sure. And they are the what, James?
The ACEs and the ARBs, and best of all, they are very common and extremely affordable.
Yeah, there's no reason why any of you, with or without protein in the urine, if you have protein in the urine, it's absolutely critical. There's no reason that you should not be on one of these very inexpensive blood pressure drugs that not only can slow decline of kidney function, but they can also potentially save your life, decrease your risk of dying from heart-related problems. So they're really important drugs. The drugs that we're talking about tonight are part of the longevity drug world. And I was just talking to James. I'm currently working on a big project about something called lifespan and health span. What will improve your health towards your later years, and what will give you more years. And so that's been my current project. And this is one of the drugs that has real great benefits. This and the GLP-1, the weight loss drugs. GLP-1 drugs are extremely expensive. I haven't looked at the SGLT2 drugs. I'm sure they're not as cheap as the ACEs or ARBs.
No.
But we'll talk about who definitely should push to get on them, and when you shouldn't be on them. So,
and just one comment real quick there. So for me, I was taking Jardiance, just got my bottle right here, and it is covered by my insurance, which is Blue Cross Blue Shield of Michigan, which is one of the ones that I seem to find is more restrictive. So I was glad they covered it. They still don't cover a GLP-1 unless you're type 2 diabetic for me. That's what the latest is from them. And I am checking it every month because I want to afford a GLP-1 and help me get thin again.
Okay, well, we're going to definitely have more shows about GLP-1. These are big time drugs. The drug we're talking about tonight and the GLP-1 drugs, these are very important drugs, and you're gonna hear more about them in further Dadvice TV shows. So what does it mean? What does SGLT mean? It means,
I actually do not know.
The S stands for sodium. The G stands for glucose. Now, if any of you have read my book, you know, or you may know if you go through the beginning, I talk about how glomerular filtrate is produced, your eGFR. So you've got these millions of tiny little blood vessels that produce this liquid called a filtrate. And that filtrate goes down tubules, which is the other part of the kidney. And at some point in the tubule, there's a place where sodium and glucose are exchanged. And what happens with this drug is you get a lot of glucose in the urine. And let me tell you, that doesn't impress me, because back in the day, I studied a drug, I think it was called acarbose. I did a lot of research. I did original research, but I've also done a lot of what they call drug studies. These are run by pharmaceutical companies or intermediaries. They're run worldwide, and they have thousands of patients involved. And I was just one of the sites. And these drugs that try to control diabetes by having some sugar in your urine, they were not impressive in terms of what they did to any of you who are diabetic know about A1C. Didn't do much to your A1C. And I think it was a surprise when they studied these SGLT2 drugs, and we're going to talk about all that, and they go, wow, these drugs seem to have benefits way beyond what we ever expected. So let's break it down. So, James, your folks and you are going to have to get used to a new name. You got used to the ACEs, which are the prils, and the ARBs, which are the TANs. You have a drug ending in pril, you're on an ACE. And a drug ending in TAN, a blood pressure drug, you're on a ARB, okay? So that's number one. The new drugs end in another kind of crazy sound. It's called dapagliflozin. Try it. Gliflozin.
Gliflozin.
Gliflozin. Okay.
It sounds like an allergy medicine.
So we've got empagliflozin, which is Jardiance. Is that the one you said you
That's
were?
the one I was on. Yep, Jardiance.
And so you folks can see if you got a bottle of these pills in your house. The canagliflozin, which is called Invokana, which just makes sense, right? And the dapagliflozin, which is called Farxiga, Farxiga. All right. The doses, I'll quickly run down these doses. The EMPA, these are once a day. The EMPA is 10 milligrams to 25 milligram pills. The Cana is a 100 milligram pill, and the DAPA is a 5 or 10 milligram pill. And we're going to see why. And these drugs have been intensively studied, and there's still ongoing studies. They found out. I'm going to give you the kind of short spiel about the drugs. They're okay to use if you're over 20 eGFR, and they originally for type 2 diabetic, but now we know they're great drugs for people who have heart failure. They could save your life potentially, and they're great drugs for kidney disease patients with diabetes or any kidney patient, GFR over 20. Unfortunately, and this is a big sad situation for a lot of type 1 diabetics, they seem to be a little bit dangerous to use for type 1 diabetics. So they're not indicated if you have type 1. I think we may eventually get down below 20, but they're saying not to use them if you're below 20 GFR. And there's some great benefits. Okay, James will tell you his benefits. You get to lose 5 pounds of weight. I think you mentioned you might have lost.
Yeah, I lost 5.6 pounds in just 1 month. I was thrilled. I'm like, holy cow, I get that GLP on top of it, and I'm going to be just dropping the pounds every morning.
Yeah. They don't drop the A1C much, just like that drug that I studied that was similar. They have been found to drop your blood pressure. Did your blood pressure go down a little bit, James?
Well, mine's always good. It's in like teens, low teens, over high 70s, 80. And it always just stays right in there.
Okay. And we're going to get into details of the studies of these 3 drugs. They decrease your risk of heart attacks and strokes, which is massive, and especially your risk of heart failure hospitalization. So here's the deal, and we're going to get into a lot of discussion about this. James, do you happen to know what your normal, for anybody without kidney disease, we lose kidney function just like we lose brain function, we lose function of all our organs. We lose about how much kidney function a year, roughly?
It's about a point a year after a certain age.
Yeah, let's say 40, like 1 to 2 points a year. Okay. These drugs will decrease the albumin excretion. And what's the way that they're measuring the urine albumin, which is the protein that we measure in the urine? What's the way to measure it, James? Remember, we talked about this a few times.
Yes, it's the albumin. It's the ACR, the albumin creatinine ratio, which is where you pee in a cup.
Exactly. The pee is sent to the lab. The lab measures the albumin and the creatinine, and that ratio is what they're going to look at in terms of how much protein you got. And the big thing is that there was a 30 to 40% decrease in the amount of protein. And this is huge. And if you are somebody that's got significant protein in the urine, this is a extremely important drug for you to hopefully slow your decline of kidney function and hopefully keep you off dialysis, at least longer than you would be if you didn't get the drug. And you know, we talked about the International Kidney Organization, the international group of experts, kidney experts. So what they recommend is they're recommended for you folks that have, with or without diabetes, over 20 GFR, and they will slow the risk and likelihood of getting the need dialysis or transplant. And they measure things like doubling of your dropping your GFR by 50% and doubling your creatinine. We used to just measure that by creatinine. If you recall, the main measure of the main lab test that should get your estimated GFR, your estimated kidney function number, is your creatinine. So doubling of the creatinine or dropping your GFR by 50%. So they looked at those. Those are the endpoints they looked at. And these drugs should certainly be, just like the ACER ARBs, if you are a patient with diabetes and CKD, you're a patient with a GFR over 20, and especially if you've got high protein, they should be part of your main treatment drugs in addition to an ACE or an ARB. So let's talk about the initial decline in your kidney function. James has something to show you.
All righty.
Tell him about it?
Yeah, let me tell him about it first, and then I will bring it up here. So I got my labs, or I'll bring it up here while I'm talking through this. All right. So as you can see, back on February 24th, I got my labs. My eGFR is holding steady at 35. It fluctuates between 33 and 35 for the last 2 years. Then I started my SGLT2 on 3/1. So March 1st, I started it. On 5/2, or maybe it was April 1st. It was April 1st I started it. On 5/2, got my labs just to see where I am, what the drop was. And it was scary. It was 22. And my potassium was high as it's ever been. My doctor immediately had me stop taking it. And then just a few days later on 5/8, she had me get another set of labs. My GFR, it bumped slightly to 24, but 22 to 24 in my mind is still pretty much the same because there's that little bit of up and down in your eGFR. But I got labs 2 days ago, and I'm excited because I am up to 29. So I am trending back towards where I started after stopping my Jardiance.
Okay, and this is a great example. And this is something that I would bet there are folks out there that went through a similar kind of a scare where you get a drop in GFR. Now, the first thing that I want you to think about is not the absolute number. So let's just say that James was up at 70 and dropped down, so here he dropped down, 13 points. So let's say somebody went from 70 down to 50. So that would be 20 points. It's not the number of points your GFR changes. We're looking at the percent change, okay? And the reason for that, and we're going to get into more detail, is that the kidney specialists say, we expect this change. It's not damaging your kidneys. So that drug didn't damage James' kidneys. It's just what they call a hemodynamic effect. It's a big word for saying it has to do with the flow going to the kidney. And it is expected. Almost everyone who starts these drugs is going to get, like, let's say 5 cc's drop. It's very, very common. James was bigger than average. Now, James, I will say, and these are all suggestions, there is a suggestion in the literature by other kidney experts that this drop may be predictive of whether you're going to have a long-term benefit. I can't say that that's been proven, okay? But that's one of the things that's out there. So what about this initial drop? What does it have to do with your long-term kidney problem? And the thinking is, it's just like with an ACE or ARB. James, do you remember that? What happens when you start an ACE or an ARB?
There is a temporary drop also. It was nowhere near this big for me because this pretty much came at about 30%, which is what they predict.
All right. Well, and that's high though. Okay, so let's go over the studies. So I've talked to you folks out there about not falling for the stuff on the internet. There's so many things they're trying to push on you that have not been studied scientifically. The drugs we're talking about tonight, and I'm going to talk about the 3 studies for each of the 3 drugs that we mentioned, and it's really interesting how this goes out. So this is double-blind, placebo-controlled, large studies going on throughout the world to find out if this stuff really works. And that's what you need. You really need good science, well-done studies. The first one was done with Cana, okay? And what they found was, on average, people dropped their GFR by about 5 points, but long-term, less decline over time. Same thing with the DAPA study. So the first study was with Cana, the second study was with DAPA. They dropped around 3 to 5 cc's, and same thing with the EMPA. Every one of these had a initial drop, and it's expected, but it should stabilize within 4 weeks. And so the question is, what do you do? What does James do? And I was just talking to James about what he should do. And here's my thinking. Although our kidney specialists say that if you're dropping less than 30%, not to worry because long term it may be beneficial, I would not agree with that. Unless you're a person that's spilling a lot of protein in the urine. If your albumin creatinine ratio that James just talked about, the ACR, is over 300, and this is US numbers, that would be over 30 in Europe, then you are at a higher risk of losing your kidney function. So in that case, I would say, yeah, I would be okay with up to 30% drop. But if you're someone like James, who doesn't have protein in the urine, I told James I'm not so sure that I would continue the drug. Now, if James comes back to his baseline and stays at his baseline, I would continue the drug. Why is that, James? Remember what we just talked about?
Well, because it's not really a drop in kidney function. It's just because the medication, it's a flow. I'm trying to remember all the words you said. It's not real. It is real in the labs, but it's not damaging my kidneys.
Exactly. That's perfectly said. But there's something else I told you. What's the other reason, even though you don't have protein in the urine, what's the other reason to consider? Okay.
It's my heart. Greatly reducing the risk of a heart attack, a stroke, which is a huge risk factor for those with kidney disease.
Exactly. Or even more importantly, heart failure. It had really impressive, and heart failure is very common in CKD patients, very, very common. It had a marked decrease in the need for going to the hospital with heart failure. Now, there are some downsides to these drugs. I guess we didn't really talk about those. When you start the drug, you can have the GFR drop. That's the biggest thing. Another kind of annoying side effect, which has to do with the fact that you got a lot of sugar around your organs where you pass water, right?
Yep.
And sugar is a great place for things to grow.
Bacteria.
Yeah, and so right in that area of where you pass in urine, it's infections in women, yeast infections, and in men, infections at the end of the penis. But those of you who are taking these drugs know that you're passing sugar water, and make sure you have good hygiene in your private part. So that's one of the main things. But the biggest thing that we're going to discuss in detail tonight is that initial drop in your GFR. So because it's the same thing with the ACE or the ARBs. When you start an ACE or an ARB, you can also expect an initial drop in GFR. And there's been a lot of reports where they've looked at the people that stopped either the ACE or ARB. We don't have enough data on the SGLT2s yet, but we got a lot of data on ACEs or ARBs because they've been around for several decades. And the folks that stopped them had a much higher risk of dying from heart-related problems. So these drugs are important for heart-related issues, whether it's heart failure, whether it's coronary artery disease, whether it's heart attacks, whether it's chest pain, angina, or the other troubles that you get with atherosclerosis, poor blood circulation to the legs, and etc. So these drugs are important to continue. Too many people stop them, and there's another reason why they're stopped, the ACEs or ARBs now. What's the other common reason, besides the initial drop in GFR, James? People on an ACE or an ARB often have them stopped for what reason? They raise something.
Does it raise, it's not potassium.
Yes, it is.
Oh, is it potassium?
It is potassium. It is potassium. It is potassium, yeah. Those drugs have an effect on the ability to get rid of potassium. So it's important to, if you're a patient with kidney disease, to be on at least one of those two types of drugs, an ACE or an ARB. And the interesting thing is that people that have started either the ACE or an ARB and they are put on one of these SGLT2 drugs, that they have less trouble with potassium, and they are less likely to stop the ACE or ARB. So one of the main things that anyone on an ACE or an ARB, okay, so by the way, the issue is if you get an initial drop, is your longer term trend going to be a slower decline or a faster decline than if you weren't on the drug? Okay, that's a tough thing to analyze. I was just talking to James about it, and I recently wrote an editorial about that in one of the main kidney journals. And if you dig in deeply to all the research, there's not a clear-cut deal where you could say, okay, if you drop 20 or 30%, are you definitely long-term going to have a slower decline? Not necessarily. But, and here's the big but, you're going to have less likelihood of dying from a heart-related problem, either for an SGLT2 or for an ACE or an ARB. So these drugs are worth considering either way. But especially if you've got significant protein in the urine, especially if it's over 300 or over 30, if you're in Europe and other countries, you want to do anything possible to slow decline of kidney function. And the foundation of that treatment is an ACE or an ARB. Now we're going to be adding the SGLT2, and maybe in the future we'll be adding the GLP-1, that's for another show, or the aldosterone antagonist, which is something that James is on, which is called what, James?
Is that spirolactin?
Spironolactone.
Spironolactone.
Right. It's an okay, this gets into the thing. Spironolactone is an aldosterone inhibitor. And there's another very expensive one that some of you are getting, which I'm not a fan of because it's way too expensive. And it's kind of dangerous because any of these aldosterone inhibitors can raise your potassium. And basically the ACE or an ARB also works through the same mechanism, so that can raise the potassium through the aldosterone effect.
We got to get those GLP-1 prices down.
Well, they will. They're going to come down. There's going to be a lot more options for the GLP-1 drugs, and the prices are going to come down. The main thing is, even like I said, even if you don't have significant protein in the urine, try to stay on the ACE or an ARB for your long-term cardiovascular benefit. But like I told James, because he does not have high protein in the urine, I would not be that aggressive of continuing it, especially if it's showing a drop in his GFR that's not recovering, because it's just not worth it in my opinion. If you, on the other hand, are troubled with, you already got cardiac disease, you already got heart failure, I might even consider it, even in James' situation. But James, and this is why, you know, you go to a doctor, and we all have different opinions, and so forth.
And next Friday is when I go to mine. It'll be we're going to have an interesting conversation.
Yeah. Well, and so now, James, you were talking about your A1C. What's your A1C? And you were concerned.
So my A1C was always below 6. It was like 5.8, 5.9. But when I was on that medication, it went up. It went to 6.4, and then it came down, the last one, 6.3.
That is bizarre. I can't explain it.
Yeah. Well, now, I mean, so part of it is, while I was on the Jardiance, I know that I was peeing out sugar, and I told my wife, hey, you don't have to be this strict with what you make. You can make sweeter food. So my diet, even though I lost weight, I was eating a lot more sugary foods and enjoying something that I haven't had for a long, long time: sweet tea, Southern sweet tea. Okay. And that's probably what did it.
Yeah, well, it could be. And well, I'll just, this is not the topic for tonight, but any of you who are diabetic, the SGLT2s are becoming first-line therapy. Metformin, SGLT2, and eventually GLP-1s are going to be available for diabetics. The reason for that, and we talked about this on other shows, is that if you got CKD, especially as your GFR is going down, you're going to be more prone to what, James? Do you remember we talked about? Diabetics that are on diabetic meds?
Low blood sugar. It'll
Exactly.
drop too low. Yeah.
Low blood sugar can kill. It can kill. As a matter of fact, I got a close friend who's a type 1 diabetic who was found unconscious. Luckily, he was found because he's got one of these continuous glucose monitor and insulin pump, and it was not working properly, and he continued to get his insulin. Insulin can cause severe hypoglycemia. And in today's world, diabetics who lose weight are getting off their insulin, which is really a dangerous drug. And the drugs that are not dangerous, and these are the old drugs, like this called sulfonylurea, glipizide, glyburide. All of these older diabetic drugs can drop your sugar real bad, but SGLT2s don't do that, and the GLP-1s don't do that, and metformin doesn't do it. So those are good drugs. But James, there's too many folks out there that are being overtreated for diabetes, and like James, is A1C is going to bounce around. Don't get your doc starting you on a diabetes treatment unless you're confirmed to have diabetes. We're overtreating diabetes. On the other hand, if you're a kidney patient and you have an abnormal A1C, slightly abnormal, I'm not opposed to using the SGLT2s. They normally will benefit your kidneys and your heart and your diabetes and your A1C. So yeah, so I would be okay with that. You want to get some questions, James? You got any questions there?
Oh yeah. We've got some questions in here. Let me hop up here to the top. And hey guys, if you guys have questions, go ahead, type them in the comments. This is great access right here to a genuine doctor, not somebody just pretending to be one on the internet. All right.
Well, Kelly
asked, are there any blood test markers for heart issues?
Okay. Well, That's interesting you talked about. I was just telling James that I was reading a book about longevity issues. And it turns out in the future, there are going to be some tests of inflammatory markers that are predictive of cardiac disease. But here's the deal. If you are a patient with CKD, you have real CKD, even if it's stage 3, right? Your GFR, even 45 to 60, and certainly 30 to 45, puts you at a higher risk of having all of the hardening of the arteries related problems, whether it be heart attacks, strokes, or heart failure, or decreased flow to your extremities with trouble with your toes and so forth, like diabetics have. And the combination, and this is very important, the combination of a abnormally low eGFR and high protein puts you at a much higher risk of getting these problems. So that's why these drugs become so important, because you're already at a high risk. And anything that can decrease your risk is going to show up on a research study. So again, the ACEs, the ARBs, the SGLT2s are going to potentially help your kidneys, but also help with in terms of cardiovascular disease. But Kelly was asking about
Soliqua?
No, ketoacidosis, about acidosis. Okay. There is a rare, with SGLT2s, ketoacidosis should not be the problem. It should not be a problem from the drug itself. If you're a type 1, then that's another story. So, and there may have been another reason, because the literature has basically said that this is a rare side effect. I'm not saying it's impossible. So if you did have it, I think it makes sense that it was stopped. And I don't know whether taking a different SGLT2 would have made a difference. Okay, you got more questions, James?
Oh, they're piling in now. They're all at the bottom. Okay. So my mom asked, do you think they're going to take Metformin off the market? And we've had other people commenting on some problems with Metformin. Scoff says Metformin destroyed his mom's kidneys.
Absolutely wrong. It is not possible. Metformin has not been shown at all to have nephrotoxicity, meaning toxic to your kidneys or damaging your kidneys. Here's what can happen with metformin, though. Metformin has a side effect that's very common. You know what that is, James?
Mm-mm.
Diarrhea. There are some
which could lead to dehydration.
Exactly. Thank you, James. You got it. You're learning. Dehydration is the commonest cause of what they call AKI, or a large drop in GFR in a short term. And my guess is, that's my guess though, that the metformin might have caused severe diarrhea and may have caused dehydration, which is reversible with fluids. So I think that it's unlikely that metformin did it. As a matter of fact, metformin, if you look at the literature on longevity and metformin, it is being looked at currently as we speak for a drug to lengthen life, to have you live longer. Ooh. So metformin doesn't cause hypoglycemia, low blood sugar. It is a great drug, and it is the drug that's basically recommended as the starting point for treating diabetes, with the SGLT2s, or if you can get it covered, the GLP-1s to come in addition. They're much safer than these other drugs that have been used, certainly much safer than insulin. Okay.
All right, Doc, why don't you scroll to the bottom, because there are a ton of questions.
Now here, so someone's
that way it'll
saying,
be faster.
I'll just put them up on the screen. You put them up on the screen.
Yep.
Irbesartan, put it back up. Irbesartan.
Wisconsin grandma, she's a regular.
Okay, irbesartan is not a diuretic, and it did not cause you to go to the hospital being dehydrated. Now, irbesartan is a what? It's a TAN. It's a TAN. What is it, James?
That's an ARB, right?
Yeah, irbesartan is a TAN, It's an ARB. It is a drug that can lower blood pressure, but it should not have anything to do with dehydration. It can lower blood pressure. Now, having your blood pressure go down too low can put you in the hospital. And one of the things I talk about on this show, and I've talked about in my book, is monitor your blood pressure. If your blood pressure gets too low, certainly if it gets below 90, or even in some cases below 100, if your kidneys and your brain and your heart are used to your blood pressure being up in the 120, 140 or higher range, if it gets down to the 90 range, you're going to get worsening kidney problems, you can get worsening heart problems, and you can even produce a stroke. So my guess is not dehydration. Irbesartan is not a diuretic, although there are combination drugs with an ACE or an ARB and a diuretic. The diuretic commonly used together in these pills, combination pills, is called what, James? Remember? HCTZ,
HCTZ, yeah.
hydrochlorothiazide. A small dose of that, together with an ACE or an ARB, increases the ability of the drug to lower blood pressure, but it also will help keep you from getting the high potassium that the ACEs or ARBs can cause. All right, you got more?
All right. Carmen says his nephrologist started him on Jardiance half of a 25 milligram since August of 2024, which I think is kind of odd since there is a 10 milligram. But anyway, his primary care physician says he should be taking 25 milligrams once a day. He's sticking with what his nephrologist says. What are your thoughts on that? Should he follow the nephrologist or the primary care physician?
Well, you put me in a tough spot. Okay, well,
with very little info too.
I need to know a lot more about it, but okay, here's my general approach is that if you're looking for the benefit to slowing loss of GFR, you want to use certainly the maximum dose of any one of these SGLT2s, and the maximum dose, you got to look up what the maximum dose is, it should be easy to find, of any one of the either an ACE or an ARB, okay? And I recently saw a very complicated person in my free clinic who had lots of problems. A drop in GFR related to SGLT2, trouble with potassium, and several other things. But a lot of protein in the urine. And my thing was, we need to try to restart the ACE or ARB and the SGLT2. And that's what I recommended, to restart it. Because you want to do the maximum ACE or ARB dose and the maximum SGLT2 dose if you're one of these people that, which is not the majority of you, by the way, it's a small percentage. If you're one of these people that has, high levels of protein in the urine. Okay, you got more?
All right. KB Bumble wants to know, what do you think of statins?
Very important. And James, I have to tell you, I was impressed. I remember looking at your LDL. It was low. It was great. It was great.
I am on a statin.
Yeah. Well, okay.
But not all my cholesterol numbers are good. One of them's not good.
No, that's fine. It's the LDL is the only one that I think has been shown consistently. If you take a statin, not you, just in general, and there are hundreds of millions of people on statins around the world. They've been around for decades, and they have consistently shown that they have benefit for decreasing the bad events from hardening of the arteries, whether it's strokes, heart attacks, decreased blood flow to your extremities, and the new goal. Okay, so the blood pressure goal from the recent research is around 110 to 130, especially if you've got, again, aggressively declining kidney function with a lot of protein. You want to get your blood pressure down in the 110 range, would be my advice. And the LDL for all of you CKD patients, because you're at a higher risk of getting hardening of the artery problems, I would shoot for an LDL below 70. And if you're diabetic, and even below 50, because the latest research is saying that we were not getting people's LDLs low enough. So that's it. I am a big fan of taking statins to get your LDL down.
Yeah, I just looked up mine. The last labs was 65. Before that, it was 58.
Yeah, no, it's fine. You're under 70. You're in a good range. It's good.
It used to be well over 100. I can't remember what it used to be, but I think it was like 140 before my doctor started me on a statin.
Yeah, those are important drugs for you folks to be on that have CKD.
Now, a couple people have asked, if you started SGLT2 and you see that drop, does it eventually improve while you continue the SGLT2, or does that like your new base right now while you're on it?
No, that's the thing, James. If you were my patient and you had protein in the urine, now what percent drop was it? What was your number again? It was from
it was 35 to 22, so about a 30 to 31%.
Yeah, so you're on the borderline, and especially, look, the kidney docs pick 30%. I'm not sure that's maybe too high, but if you were one of these people that got started on an SGLT2 because you had trouble with a GFR that's going down, you got significant protein in the urine, I wouldn't necessarily stop it. I would follow it, because what happens is, as they found in the research studies, when you recheck at 30 days or 60 days or 90 days, most of the people are back to their baseline. So it was a functional problem with the kidney, and it corrected. So, and most doctors are going to be scared, and I don't blame them. When they see a patient's GFR drop, they're going to be scared. But expect, at least a 3 to 5 point drop, on average. And I would say, even a 5 or 10% drop or 10 or 15% drop, don't stop the drug, especially if you're one of these folks that has protein in the urine, and just monitor it. But I can't tell your docs what to do. A lot of docs are going to be afraid, and that's why people have stopped their ACE or ARB, because the GFR has gone down, and they missed out on the benefit long term, which is clearly a mistake.
Yeah, and my doc, I know she was worried I would panic. She doesn't know me well enough. When I saw the labs, I get them on my phone, I was like, whoa, that's a big drop. I'll talk to my doctor next week. And I got my results, I think it was on a Thursday or a Friday. And she called me Saturday morning just to say, hey, James, I saw your numbers. I know it dropped. Don't panic. Stop taking the medication. We're going to take your labs again in a few days, see if it starts going back up, which it did. So I'm looking forward to talking to her next Friday.
Okay, I'm going to run through these real quick. I'm going to go from bottom up. Okay, Stacy, do you have to have a high BMI or diabetes to be eligible for SGLT? No. It is now recommended for anyone that has kidney disease with or without diabetes with a GFR over 20. Sheila said, is 100 ACR, albumin creatinine, significant protein in the urine? Yeah, it's significant. It's not severe. Now, I'm assuming, Sheila, are you in the U.S.? Because if you're outside the U.S., 100 would be very high, okay? That would be equivalent to 1,000 in the U.S. Karen, should you be on an ACE or an ARB, on spironolactone, HCTZ, which is what James is on, and metoprolol and Crestor, no protein in the urine, 65 years. Karen, again, I think the ACE or ARBs should have been the first drug that your doctor should have started you on to treat your high blood pressure, because people with kidney disease are at risk of getting cardiovascular problems, and that is that's the drug that you should be on to start with. So yeah, you should have been on an ACE or an ARB, and I would recommend it. Kelly, we talked about the LDL 74. Kelly, it's very hard to affect your LDL with diet. I'm not saying it's impossible. I certainly think that if you've been on a high protein meat-based diet and you go onto a plant-based diet, it certainly could have an effect. But these drugs are safe, they're remarkably effective, and they have remarkable benefits. I wouldn't hesitate to get on a drug or increase the dose of one of these drugs.
And for me, they're affordable, which is really important.
And they're very affordable, yeah. Lisa said, stable GFR 55, dropped to 43. Doc wants to put me on. Yeah, no problem. No proteinuria, no hypertension, no diabetes, no meds. Abnormal except creatinine. So, Lisa, you're 55. I think that, so your GFR is 43 now. I would say it's, again, because of the potential cardiovascular benefit, it's worth considering. It's not critical, but it's certainly worth considering. And someone takes statins and COQ. I think that's a supplement, James. And
CoQ10. It's one of the ones that my doctor has me take. It's supposedly good for your heart.
I think any supplement, I would say, is a waste of money. I don't know why your doctor's recommending it. And this and the book, I told James, there's another book on longevity written by a world-renowned cardiologist, has the same approach that I do with regards to supplements. Absolutely not worth the money. None of them. And again, you need double randomized control, double-blind studies to see if something works. And that's why we know about these SGLT2s. Okay. James, okay, these are just, no, don't, Wisconsin grandma, again, forget supplements to lower blood pressure. Take, okay, first drug to be on, ACE or an ARB for your blood pressure. And then you could add diuretics and you can add other drugs. There's a lot. We've done a couple shows on blood pressure, and I'd highly recommend you go take a look at that. Yeah, you could be on, Kelly, you could be on an SGLT2 and a GLP-1. And I think the future, the GLP-1s seem to have the same kind of benefits in terms of decreasing your heart-related problems, in addition to losing weight, in addition to helping with diabetes. So yeah, those drugs will eventually get cheap. They'll get cheap as statins. It's going to take some time. But yeah, I think people are going to be on both SGLT2s and GLP-1. Okay. Taking HCTZ. Okay. You got anything else, James? Okay. Nephrologist. Yeah. Okay.
No, not unless something new has come in.
Okay. Yeah. So Karen is talking about diet and exercise. Look, she thinks that improved the GFR 37 to 43. I'm not saying it didn't, but I certainly think that being on, and I read my book over, and I talk about something called my SMART diet. My SMART diet is nothing fancy. It's just a relatively low protein diet, which I think is recommended for CKD patients for long-term, slowing progression. And it has, plant-based and lots of fiber. And it's not going to hurt your kidneys. I wouldn't necessarily attribute any change of GFR to a diet.
All right, I see a good one. Johanna Travis says, what can I limit diet-wise to lower protein in urine? We get this question quite often.
Yeah, there's nothing that you should do diet-wise to lower protein in the urine. On the other hand, those people who are on red meat diets tend to have higher risk of developing progressive CKD and progressive declines in GFR. It's just an association. There's nothing specifically that you're going to have in your diet that's going to affect whether your kidneys are going to be leaking out protein. It has nothing to do with that. These are long-term effects on the kidney, and they have to do with the pressure inside the kidney and how it affects, whether or not you're going to have protein coming out. But no, there's nothing in the diet per se that should have any effect on GFR, had any effect on proteinuria. But over the long run, you want to be on a plant-based diet, and I think my SMART diet, that certainly makes sense. Can lisinopril cause creatinine to go up on at 8 years for CKD stage 4? Yeah, I mean, as we talked about, Debbie, an ACE or an ARB can raise creatinine, which in turn means your GFR will be down a little bit. But it's the right drug to be on. And I don't know anything more about your CKD4, but I think that drug makes sense to be on for your cardiovascular benefit and potentially for your kidney benefits. I have no idea what berberine is. You know what it is, James?
Do not know what that one is.
Okay, all right. Okay. And there's another one I have no idea. Seaweed. Yeah, again, Raymond, please stay away from any of these seaweeds or these other supplements. They're not regulated. They can have heavy metals in it. They can have potassium in it. They can poison your kidneys. Please, anyone listening to the show, save your money. Don't take these supplements. Take only things that are FDA-approved drugs would be my advice. Okay, my doctor has me on irbesartan. Now, it's just someone, again, this is the same person, Wisconsin. Irbesartan, if you're having trouble lowering the blood pressure, you need to probably be on more drugs. And people that have complex blood pressure problems need to be on probably 2 or 3 drugs.
Yeah. That's me. I have a long list of them.
Yeah.
Blood pressure, the cholesterol, the uric acid, the water pill. That's for blood pressure.
Yeah. Well, yeah. And if your doctor is having trouble getting your blood pressure down, you need to think about several things. Do you have white coat hypertension? What's your blood pressure when you're at home? I suggest people check your blood pressure at home because that's a better indicator of what your average blood pressure is doing rather than just taking a reading in your doctor's office. And if your blood pressure is not being controlled, tell your doctor. And if that doctor can't do it, say, can you send me to someone who can? And for sure, controlling your blood pressure is an important factor. We hadn't talked about it tonight. To slow progression of kidney disease. You don't want to just think about ACEs or ARBs or SGLT2s or GLP-1s, but you want to control blood pressure. And I think getting your LDL down may have some benefit as well. So, yeah, the first thing you want to do is make sure you get your blood pressure to goal level, and that will help you protect your kidneys.
Yeah, and I take, for me, it took a long time, or it felt like long. It took months for the doctors to find the right combination of medication to get my blood pressure where it should be. And I'm thrilled with where it is. So every time, like when I got my new doctor, she was like, maybe we can get you off some of these pills. I was like, don't mess with them unless you really know for sure I can stop. I don't want my blood pressure to go up because that's not good for my kidneys. I love it being controlled.
Okay, Scott, not scoff. Elderly CKD3. Well, let's stop right there and say, please, if someone's got CKD3 and they're elderly, they probably don't have kidney disease. So it's irrelevant about your mom not liking veggies. And I think generally speaking, a plant-based diet with veggies and fruits is certainly a good idea for everyone. But if someone is elderly and their GFR is in the 3A stage, which is around 45 to 60, they probably do not have CKD. And there's way, way too many people that are being scared because their normal value should have been 60 to 70, and it's 50, and they're panicking. But this is just very common. You're not going to have a problem with your kidneys that's going to shorten your life. You're not going to wind up on dialysis or needing a transplant. We've had way too many people that have been scared because they're told they have.
Speaking of that, Dr. Rowe, earlier today, someone emailed me their labs, and they were, I get these quite common. I'm scared to death. Yeah. What should I ask my doctor? And I looked at it. Their eGFR was 116. And they looked it up and said, it's not 120. I've got kidney disease. And they were worried. And they were 39 years old. So I got to give them some good news.
Yeah.
And they had no protein in their urine or any other issues.
All right, I'm looking at one thing. Are we done, James?
Yeah, we are at the top of the hour.
Okay.
Do you want to? Yeah. I'm going to bring you back up on screen fully so they can see your the QR code. Dr. Rowe volunteers his time to come on here. He prepares for this. And as you guys can see, he's easy to understand. He's right to the point. And if you have not read his book, it is a great book. I wish my doctor would have handed it to me when I was diagnosed. It could have saved so much panic and worry and me doing the wrong thing for a while in the beginning, thinking I had to eat this, no potassium, none of this, none of that. His book just makes it all really easy to understand. It's very straightforward. So if you're interested in getting it, it's called, let me bring it up here. You guys can see it. It is called Learn the Facts About Kidney Disease. Dr. Rowe likes to keep an eye on his numbers. So let's get his book up there. Let's keep those numbers going. And if you do buy it from Amazon, write a review. That'll help it get recommended above a lot of the other books that are just too hard to understand because they're written for doctors, not for people like us. Look at this. People say, love your book, Dr. Rowe. There's Karen. My mom says, love him. Sheila says, thank you. We got lots of great comments here. Thanking you for your information, which is extremely helpful for everyone here. All right. So that is, let's see, what is it? It's the end of the month. This is the last video of the month. I will be back next week because Jen is always here the first Tuesday of every month. Remember, let me see. Is that next Tuesday? I'm looking at it. Oh, no. Jen and I are not doing June because she is traveling, I believe. Yeah, we are not doing June. But I will have one. I have multiple ones coming up. Oh, I did want to announce Cleveland next weekend. Not this one coming up, but next weekend, Kidney Walk in Cleveland. It's downtown right on the lake. I will be there. You guys can spot me really easy. First of all, I'm not quiet, especially when it's at a Kidney Walk. I'm up there, woohoo, cheering everyone up, visiting all the vendors that are there that are supporting us. Lots of them give out coupons and free samples, like those healthier sodas and things like that. So I hope to see a lot of you there. But thanks again, Dr. Rowe. This has been fantastic. And I will let you know what my doctor tells me next Friday when I visit her. All right, everybody. Thank you so much. And we'll see you in the next video. Bye, everyone.